Hello everybody. Here I am there today to speak a few words about uterine fibroids and its significance to fertility. As we know, many of our own relatives or friends do suffer from fertility problems due to fibroids, and there are lots of queries on to whether as to all fibroids have to be operated or not, and what kind of treatment modalities are available for fibroids, so on and so forth. So to look into the issue of fibroid, so all of us know what fibroid is. It's a tumor, benign tumor that arises from the smooth muscles of the uterus, and its potential to turn into malignancy is very low. So what are the three different kinds of fibroids that we are looking into? The first is the subserosal, the second is intramural, and third is submucosal, depending on the layer of the uterus that it arises from. Those fibroids that arise from the outer serosal layer of the uterus and prop out of the uterus into the peritoneal cavity are called the subserous fibroids. Those fibroids that develop from the myometrium and either grow outwards towards the peritoneal cavity or inwards into the endometrial cavity are the intramural fibroids, and those fibroids that developed within the endometrial cavity are the submucosal fibroids. So which fibroid that is too worrying for us is obviously the submucosal ones, because they grow into the endometrial cavity, they deny implantation of the embryo, and they are the main reason for the recurrent implantation failure and the miscarriages. So the next group of fibroids that are causing issues and worrying us is the intramural fibroids that tend to grow into the endometrial cavity. The less harmful ones are the intramural ones away from the endometrial cavity or growing outwards, and the least troublesome are the subserosal fibroids. So let me take each fibroid and discuss few words on it. Taking the subserosal fibroids, the issues that are mainly met with are they tend to be little anemic because of the growth of the tumor, and they have a vague abdominal pain, and depending on the location of the fibroid, patients could report to us with either retention of urine or increased frequency of urine and difficulty in passing stools and so on. So unless or otherwise the fibroid is quite big to alter the position of the uterus and cause fertility issues, like it can either make the uterus acutely retroverted and thus be the reason for fertility. The next one is the intramural fibroid. These fibroids, when they just restrict themselves to the myometrial wall, and when they don't intend on the endometrial cavity or distort the cavity, they do not cause much trouble. But when they tend to distort the endometrial cavity, or when they tend to alter the cavity, they become the reason for the fertility issues. So such fibroids have to be dealt with either laparoscopically or hysteroscopically based on their location. The third group of fibroids are the submucosal fibroids, which definitely needs resection by hysteroscope. So there should be lots of expertise required for a hysteroscopic submucosal fibroid, because we have to resect with care that we do not remove the layer of the endometrium, which can lead to an Asherman's later on. And similarly, anyone who is good at laparoscopy will be fit enough to remove a subserosal fibroid that's growing out of the uterus. And there are few fibroids, depending on their location, they are either called as the lateral wall or the broad ligament fibroids. So these fibroids have to be taken care, and when they are symptomatic, and when removing, we have to be careful that the ureters pass through that way and we do not injure the ureters. Some fibroids may be intramural, but they might be closing the ostia, thereby causing a tubal block. So these fibroids have to be dealt with very carefully. Very good expertise can remove them hysteroscopically. And otherwise, there are medical treatments available, even though not much followed. We have been long time following GnRH analog injections, which have been of very good use for us to decrease the size of the fibroids, and they are being much used either prior to embryo transfer to decrease the size of the fibroid, prior to the embryo transfer. See, when we find an intramural fibroid encroaching into the endometrial cavity or a bad adenomyoma which we are not happy in resecting them, in such cases we use this GnRH analogs to suppress the size of the fibroid or the adenomyoma prior to transfer, and then we follow transferring. And there have been lot of instances when we have had patients with multiple fibroids who report to us. So we do a proper 3D ultrasound scanning on them. We look at the size of the uterus, the size of the myomas, the relationship of the myoma with the endometrial cavity, and the location of the myoma, and then we decide whether they need a surgical intervention or they don't need. There are many instances when we have been doing IVF and embryo transfer on patients with multiple fibroids without surgical intervention. We do not believe that all fibroids have to be removed. So we look at the fibroid, and if it is very far away from our endometrial cavity, and if we feel these fibroids are not going to be on our way during our embryo transfer, nor they are going to impinge on the embryo or the implantation, we forget about the fibroids and we go ahead with our embryo transfer and we transfer the embryos. But at the same instance, if it is going to be a small intramural fibroid that is close to the cavity, impinging or encroaching into the cavity, and which we think can impair the implantation, we don't mind removing these fibroid prior to our embryo transfer technique. So it is the opinion of each fertility consultant dealing with a particular patient as to whether to remove or not to remove the fibroid, and the main issues that has to be taken into account to make a decision is to look at the location, the size, the duration of fertility, the age at which the patient presents to us, and the symptoms of what they have presented with. So taking into account of all these things, a collective decision has to be made with the patient as to whether a surgical intervention is required or not for the fertility treatment. And there are a lot of instances when we have allowed our patients to conceive with the fibroids. We give them a proper counseling prior to that. We counsel them that the fibroids can grow along with the pregnancy, and if they land up in having a cesarean section, there are plenty of instances when we have removed these fibroids during the cesarean section. We are sure that these patients do not bleed badly during the surgical intervention at the time of cesarean. It is just like how you do a C-section. You remove these fibroids. There's lots of misconceptions that when you remove the myomas during the cesarean section, they bleed very badly, but we have not dealt with such bad situations. So we keep their hemoglobin levels at proper correction prior to their delivery, and if they land up in a cesarean section, we do not restrict ourselves and we remove these fibroids and give them a proper correction. So I think there have been few main things which I have highlighted about fibroids, which would be of real help to you. Thank you.